Good morning, everyone. Good morning. So, just in case you forgot, my name is Christina. I am a care transitions interventions coach. I am a registered nurse with a Bachelor's of Science in Nursing. And I think I forgot to tell you last time, I'm working towards my master's. So, last lecture and today's lecture is part of my practicum. I'm 2 classes away from receiving my master's at the University of Phoenix. I would like to start by thanking my guest. There's one more coming, but this is my sister Maria, and maybe she can tell you just a little thing about her.
Hi everyone, my name is Maria, and she's the youngest one, and she's the first one that graduated from nursing school, and then after her, I became a nurse. I am a registered nurse working for Sharp Grossman Hospital, and the oldest one is a nurse as well, so she's our role model.
And this is Anthony.
Hi.
He's a little shy. And this is Tammy.
Hi, I'm also a care transitions coach. I work for Scripps Healthcare. I've been a nurse for 30 years. The first 10 years of my career was flight nursing for the Air Force. I have my PhD in nursing. And I love what I do, and I have a great team to work with, so if you get an opportunity to do it, do it.
Thank you, Tammy. Thank you all. So for today, part 2 of the CTI model, CTI coaching, you are actually going to get to apply the model on a live patient. And you will be able to do the simulation from the face-to-face to the phone call to the home visit, and hopefully identify some barriers that might keep the patient or the caregiver or the family from achieving their personal health. So just to review, do you remember what it is that we have to do during the face-to-face intervention? Okay. So introduce yourself. Hi, my name is Christina. I am a coach, or I am at Scripps we call ourselves navigator nurses. My responsibility is to follow up on you once you get discharged from the hospital. This is a free service, right? Because we are kind of selling ourselves to them because this is optional. And then we tell them it's a 1 home visit deal. That's it. And then after that 1 home visit, we follow up with a phone call once a week for up to 3 to 4 weeks. Total, we follow up with the patient for a total of 30 days or 1 month. And then the 4 pillars of the care transitions interventions model is the personal health record. And by the way, you can pull it out because that's what you're going to use to hand off to the patient when you see the patient face to face, or if you forget when you see the patient in the home setting case scenario. Give the personal health record to the patient, and then, once the patient gets discharged, you call the patient, you go visit the patient, and that's when you go over the PCP follow-up appointment, and ensure that the patient has a follow-up appointment with the primary care provider. You ensure the patient has knowledge of the red flags or the signs and symptoms that led to the hospitalization. And last but not least, that's usually where I personally take most of my time, because I identify a lot of mistakes in this pillar. And actually, I want you to be very vigilant, because when it comes to medication reconciliation, there might be a trick in there in the medications. So just pay close attention to that. Make sure that not just that you know what medication the patient is taking, but the important thing is, does the patient know? Can they read? Do they have the correct dose? Are they taking it at the correct time? So those are just a little review.
Christina,
Yes.
can I add something to the
Of course.
face? You also want to verify their demographics, make sure you have the right information on your face sheet. And for me, I'm sure for the rest of the team, it also gives you a sense of whether that's a safe patient to see on the outside. But we only follow patients that have a phone, and there is a free phone program in California, so everyone should have one, but we do occasionally get referrals that don't have phones.
Absolutely, and, yes.
I just have, in regards to when you're actually calling, because you do have to be concerned about patients' privacy, how would you call them? Do you ask for them by their full name and then confirm it's them before even beginning to speak to them about, I'm coming to follow up with you? Because you want to make sure it's the correct patient. You also don't know who you actually are allowed to speak with on behalf of that particular patient. So
Right.
how would you normally, when you're calling?
So when I usually call, it's usually the patient or the patient's family. And the way I do it is I don't share any information with them. I call and say, hi, is this Mr. Jesus? They'll be yes or no, and then I'll go from there. If it's a family member, I ask, I was just calling to follow up on him, how is he doing? It might be the wife or it might be the sister. And they are very open to sharing that information because remember, by that time, they already know that you're coming, or they, ideally they would know. Even if you did not see the patient face to face in the hospital setting, they're very open because when they have questions, they really want your help. They really want you there, and they're really happy that this is a free service that they don't have to pay. Do you have anything else to add?
I generally ask my patients if it's okay to share information with the family. I've never had one to say no. And I don't usually, when I'm calling, leave a message on the machine. I'll try to keep calling until I actually get a contact. Because that could be a violation of HIPAA if you leave that information on the telephone. And it happens to be the wrong number.
And then I've had instances where I go visit the patient and, the patient has like 6 family members, so before I start my intervention, I make sure that I ask the patient, is it okay if all your family members are present? And they always say yes, because in fact, they want the support that they have from their family. And I think it's great, actually, there's studies that suggest that the bigger your support system is, the longer you live. Okay, so what I'm going to do right now is I'm going to do a simulation with my sister, Maria. And I want you to take notes if you want, because I want you to tell me what I did wrong. Discharged from the hospital, I might only get the opportunity to read, or some of the time, I might only get the opportunity to read just that. Okay? So this is a 61-year-old female with that cheek complaint, with those diagnoses, and with those instructions. So take a couple minutes to read it.
Now, when they're sitting up front, can you see them, or would you rather them be over here? Can you all see them in the back from their, when they're sitting down?
Yeah.
Low and, okay.
So we'll begin with the face-to-face, okay? Hi, Ms. Maria. My name is Christina. I am a nurse here at Scripps Hospital. I just wanted to tell you a little bit about the service that we offer here at Scripps. This is a free service, and what we do is we visit the patient at home just one time, and then after that we follow up with a phone call once a week for up to 3 weeks. How does that sound? Okay, bye. Thank you. So, what did I do wrong? How many things did I do wrong? Say that again?
You're not saying she understood you
Correct.
or what language she speaks.
Did not.
You didn't give her a chance to respond to that. Did it
Correct.
have a conversation with her?
Huh?
Did it have like a actual intimate conversation?
Right. It was not effective communication talked about this last week, effective communication, there's actually a transfer of information, right? So that did not happen, and all she was doing was smiling and nodding. If there's, I think that's very common in the population I serve. Tammy, I don't know if you have the same experience, because we actually kind of serve the same underserved population. That when I see a patient smile and nod, to me that's a red flag, because that tells me absolutely nothing. You know, does the patient speak my language? Does the patient have a vision problem? Do they have a hearing problem? Is it a literacy problem?
Open-ended question,
Mm-hmm.
make them have to answer something. And sit down when you talk to them.
At the same level. So, any other comments? Any other things that you noticed? No? Okay. So let's say I'm gonna call her, or I call her and then I'm going to try to schedule a home visit. Okay? Ring, ring. Hello. Hi, Miss Maria, this is Christina. I am the nurse that spoke with you at the hospital. Just wanted to follow up, see how you're doing after you were discharged from the hospital.
Oh, nice to hear from you.
So I was wondering if I can visit you at home today.
No, not today, because my husband is not home.
Oh, okay. Would tomorrow work for you?
Sure, tomorrow.
Okay. Do you prefer morning or afternoon?
Afternoons.
Okay, so I'll see you tomorrow. Thank you.
Okay.
Bye. Did I miss anything? What did I miss?
Hi.
Uh-huh.
You didn't confirm this, sir.
Correct.
Confirm the patient.
Correct. Correct. What else?
You just assumed it was her on the phone?
Mhm.
Started giving up the information.
Correct. Yes, all of those things. So when you call, make sure you verify the patient's name, the patient's date of birth, the patient's address, and there might be some things that you want to tell the patient, right? Because usually, when I first started practicing this model, I would just call the patient, and I probably, would do the same thing that I did right now. But then you learn, you want to make sure that you ask them to take out all their medications and their discharge instructions, because it has been my experience that about 99% of patients don't read their discharge instructions. And in the discharge instructions is where you will find about 99% of the questions they have for you. Yes?
Is it good practice then, when you do the first initial face-to-face, you ask them specific timeframes, like do you work? What would be good dates and times for you? And then give them a definite, I will be trying to call you within these 2 hours to set up a follow-up at your house. Do you
Absolutely.
usually do that at the face-to-face?
You could do that. Yeah, that would be great. Any other questions?
Just when you said pull out their medications, make sure you ask them to pull everything. Every medication that they have in the home, whether it's a prescription or a non-prescription, if it's a vitamin, if it's a cream or an ointment, have them bring everything out.
Yes, absolutely.
And I usually tell them when I call to set up my visit, I ask them, right out of the head. Oh, if they picked up any discharge prescriptions that they were given on discharge. And if they haven't, I ask them to go ahead and do that.
Yeah, because sometimes it has been my experience as well that patients don't know, or they're in such a hurry to get home to feed their dog or to take care of a loved one, that they don't really care about themselves first, and so they get home, and when I'm looking through the discharge paperwork, there's a prescription. They have not filled it. So just make sure you tell them, make sure you take out every medication and have your discharge instructions. Because if you do it once you get home, it's going to take them about 15 minutes to do that. So then that way you can maximize your time. Yes.
Just something else to bring up, you might want to, doing home care visits for a long time, any special instructions about how to get into your house? Sometimes people live in a weird, they're behind another house, or their alley is here, where do you park? All those kinds of questions. Plus, do they have any pets
Right.
that are in there? If you're allergic to pets, or you hate dogs and you're afraid of dogs, good time to ask is on the phone
Yes.
versus in the driveway when you're being accosted by a Saint Bernard.
Yeah, a code, there's the condominium complexes that are gated and they need a code. That has happened to me. I forget to ask, and then there I am waiting, and then of course the patient's not answering because the phone is off, right? So then I have to wait till someone comes and opens the door. So those are just little things that you might want to ask. Is there anything specific I need to know about the community where you live? Okay. And then lastly, the home visits. So I'm going to do, let's see what okay, so I'll do this really quick. So here I am in the home, right? And so I made it through home safely. I am visiting her. Hi, Ms. Maria. My name is Christina. I am the nurse with Scripps Hospital. Remember I told you I was going to visit you today?
Oh, yes, I do remember.
Oh, okay. Well, I just wanted to ask you if you have any questions for me. Or more questions do you have for me?
No, I don't have any questions.
No? Okay, I do have a couple questions for you. Do you have your follow-up appointment with your primary doctor?
No, I don't have it.
Okay, let me call and schedule it for you. Hi, I'm going to schedule an appointment with Dr. X. Okay, next week, Monday? Perfect. Okay, how about any questions regarding the reason why you went to the hospital?
I was just not feeling good.
Okay. Well, it says that you were in the hospital for chest pain.
Oh, that's right, I remember now.
Do you know why? Why you were having chest pain?
No, that's why I went to the hospital.
Oh, okay. Well, next time you can go to the hospital as well as chest pain. Okay. And how about your medications? Do you have any questions regarding your medications? I see you have a glucometer here. Do you know how to use it?
Yeah.
You do? Okay, let's just pretend she said no. She doesn't know how to use it.
My husband knows, and he's the one
Oh.
that checks the glucose for me.
I see, but you don't know.
No,
Oh.
but I don't have to because he does everything for me.
Okay, well that's very easy. Let me show you how to do it, okay? So this is the glucometer. This is the testing strip. This is the lancet. So what you do is you're gonna wash your hands, you're gonna clean it with the alcohol swab, and then you're gonna let it dry, you're gonna blow on it, and then you're gonna poke yourself, and then immediately the first drop you're gonna take the sugar level. Okay?
Okay,
You got it?
Yeah.
Okay, perfect.
I'll do it now.
Do you have any other questions for me?
No.
Okay, great. All right, well I gotta go now. I gotta go to my next visit. Bye.
Bye, nice to see you.
Bye. So, what was that? Really bad, right? So let's begin with the first thing, the follow-up appointment with the primary doctor.
They should call or do it themselves.
And what if she doesn't know how?
You can do speakerphone and guide her through steps.
Absolutely. And what if she doesn't feel comfortable doing it because she has never done it?
Yeah, my husband does it for me.
You'll wait there with her and do it together. First you practice.
Mhm.
Role play her.
Exactly. Or before that, you can do the simulation, right? So you can do a simulation within the simulation. And I have done that because believe it or not, there's 60, 70-year-olds who have never called a doctor, who have always had someone call the doctor for them. And if you take a look at the last page of your PHR, the personal health record, there's a space, there's like a, what is it called? A template, yes, a template to guide the patient through the process of calling the doctor. So you can simulate that with the patient.
So I've had patients who are discharged, and on the discharge note it says, primary, follow-up primary in 1 to 2 weeks. So they'll think, or they'll tell me, I don't need to call them for 1 to 2 weeks. Why are you making me do it now? They don't quite get the gist that if you call in 2 weeks, you're not gonna get a visit very quick after that.
Right. That is very common. A lot of my patients think that because it says, you know, a PCP appointment within 1 to 2 weeks. They wait 1 to 2 weeks and then they call. But it's not like that. And that's why we make it, we try to make it there within the first 72 hours post-discharge. Because if we don't, you know, they go past, you know, 2 weeks, they're more likely to be readmitted. And there's studies that suggest that if a patient sees the PCP within the first 5 days post-discharge, they're less likely to be readmitted. So that is huge. They need to know. And remember, your job is not to do for them. Your job is to empower them, to ensure that they can do this when you're not there. Okay? So what about, yes?
Another misunderstanding is that they think that if you put PCP in 2 weeks, they think that you made the appointment for them. And they all they have to do is show up.
Yes, yes. So you want to ask specific or open questions, I should say, to make sure that they know that they need to go see their primary doctor, that they have their appointment. In transportation, that's a huge one. That's a huge one in our population because they don't have a car, you know, so they might need additional resources with that. So then I went over a little bit of the signs and symptoms that led to the hospitalization with her. She said that she had chest pain, remember? What did I do? What did I do wrong in that section? Right. And that's the opposite of what we want, right? Obviously, we want her to go to the hospital if needed, but we want to prevent it if it can be prevented. For example, one of my sisters-in-law ended up going to see the primary care doctor after she had a huge dinner with like an 8-ounce New York steak. You know, she's not used to eating late. So she had like acid reflux, which manifested as chest pain, and then she freaked out, and she didn't go to the ER. She went to see her PCP. But sometimes the elderly population, they just see the ER as like their primary care. Obviously, if they need to go, they need to go. But try to find out, okay, well, were you under stress? Did you have a big meal the last night? Did you eat a lot of acid foods, right? Does the patient have a history of acid reflux? Most of the time, there is something there that led to the hospitalization. It was because they got in a fight with their loved one, you know, or because it's coming close to the day their loved one died, you know. That has been my experience. Most of the time, it's something emotional that caused them anxiety that led them to the hospital. And sometimes they have their medications, their nitro. They're supposed to take it, but guess what? They didn't take it because they couldn't find it, because it's expired, or because they just don't know how. Because the instructions for the nitro are very specific, right? You know, 1 tablet under the tongue every 5 minutes. If it doesn't work on the 3rd one, you call 911. And sometimes patients don't know that. They don't know that the nitro is for chest pain.
How do you know nitro is active? It should tingle under your tongue. If you put it under your tongue and you feel no sensation, it's probably not an active Lopinavir nitro. The spray is what a lot of my patients get now instead of the actual pills, because the spray lasts longer.
You want to make sure that they're keeping it in a environment that doesn't have a lot of light, because the light itself will make it ineffective. Okay, so those are all the things that I want you to be thinking about when you are doing your simulation. And then lastly, Did I go over the medications with you?
Just ask me if I had any questions.
So that was horrible, right? I want you to take out all the medications. And I know that you can read, but I want you to make sure that the patient can read. I want you to you know, as much as you can, sit on your hands and don't touch that personal health record. You know, empower her to take charge of it. Empower her to write on it. I mean, obviously sometimes we get patients that are, you know, 80-year-old with rheumatoid arthritis and they can't do it. And in that specific situation, I do help them. But if the patient can read and write, because sometimes they can't, right? So then I have to come up with ways by asking them. So how can I help you to take your medications on time, right? So that you know when to take them. You know, I've had instances where I make a little picture of a sun so that they know it's in the morning, and then a picture of a moon so that they know it's at night. But I ask them. I don't tell them. I ask them to tell me, what can I do to help you? How will you remember with those limitations that you have? If you cannot see, if you cannot hear, perhaps. Okay. So what time is it? What questions do you have for me?
The other thing you did was blow on.
Oh, no, okay. Did you guys catch that? No, okay, horrible technique, right? You're not supposed to blow on it. You're not supposed to use the first drop, right?
I was gonna ask if it's different when they're in a home versus when
No, same. You know, wipe it down with alcohol. Wash the hands. That's number one. Oh, I always when they're newly diagnosed diabetics, that's one of the first things that I make sure that they know. There has been patients who received the teaching in the hospital, and when they get home, they completely forget. So when I go home and they ask me to help them, I say absolutely. I want to make sure that you know. So why don't you show me what it is that you remember? Tell me what it is that you remember. And sometimes, just by allowing them that opportunity, they can do it. You know, and they might. This one time I remember, the only thing she forgot was to turn on the glucometer. That's the only thing. She had everything down, but it was just that one little step that she missed. It's to be expected, right? You're in the hospital. You're not in an environment conducive to learning. Really, it's very stressful. And who wants to be in the hospital? So I know that she knows how to do it because she did it right then in front of me. Let me share with you, as I'm speaking about this. A couple of years ago, a friend of mine shared a story about a patient who was taught to inject herself with insulin. And she was taught using an orange, right? So have you guys ever practiced using an orange? It's very common in Mexico. I think they have the nursing students do that. So you don't really practice on yourself. You practice by injecting on the orange. Well, fast forward a week later, the patient returns to the hospital, and everyone is perplexed. You know, what happened? And so they ask the patient, and actually it was the family. So the family member comes up to the doctor and says, I don't know what happened. We've been injecting the orange. This is a true story. So as a nurse, like, I'm thinking about that, and I'm like, if I was the nurse that taught this patient, I would have felt horrible. Because clearly, whoever taught this patient did not evaluate, right? We want to make sure that the patient knows, not just that we know that it's not supposed to be on the orange, but did anyone tell this patient, right? Okay, so I want you to break into groups of 2 groups of 4 and 3 groups of 3, and then I'm gonna have you meet with one of my patients.